Nagy Habib from MiNA Therapeutics Ltd. The title of the talk is Drugging Transcription Factors with Small Activating RNAs, a Novel Approach for Enhancing Bone Marrow Therapy for Monogenic Rare Diseases.
Thank you very much. Ladies and gentlemen, it's a great pleasure for me to have the opportunity to tell you about RNA activation of transcription factor in rare genetic disease, and in particular in MPS I. So I will be going through the introduction, the mechanism of action, and in MPS I. We all know about mRNA with the COVID vaccine, and the last lecture was about siRNA, how you can downregulate protein or gene expression. The object of my talk is RNA activation, how you can activate gene expression in order to increase a missing protein. And this has a lot of application. Top of the pyramid, you can see in bone marrow transplant. Patients with MPS I, they get bone marrow transplant, but they have a lot of residual disease. And how can we increase the IDUA expression in this donor cell? A lot of diseases have haploinsufficiency, where one allele is wild type, the other one is mutated. We can make the wild type allele work harder, and so on. So just to clarify the difference between activation and inhibition, both are universal. It can work on any gene. saRNA in diseases where there is downregulation of the gene, the siRNA is the reverse. saRNA work on transcription, siRNA work on translation. Transcription happens in the nucleus, while translation happens in the cytoplasm. So it's about turning the volume on. The mechanism of action is that the double-strand RNA, 21 nucleotide long, will go into the cytoplasm, and the active strand with the ARGO2 go to the nucleus and find a sequence on the DNA that corresponds to it. And then there is RNA polymerase and transcription start. In a graphical way, the DNA, when it's not functioning, it's closed. And all what we try to do is to open it up in order to allow the RNA polymerase to go in. And in a disease where the protein is not expressed, we try to bring it up to normal level, to physiological level. We can also activate a gene that is repressed. For example, interleukin-10 in autoimmune disease, when it is closed and not expressed, we can increase the expression by 20-fold. And the same thing, we can do it with the fetal hemoglobin in sickle cell disease. I'm going to talk about SEPPA. SEPPA is the master regulator of the myeloid cell. What does that mean? It regulates over 500 genes, and one of them is the IDUA gene. And you can see here how we can upregulate the SEPPA twofold with saRNA. I'm not going to go through the process how to get the oligonucleotide. However, we succeeded to get it into a lipid nanoparticle produced by BioNTech, and that has been given safely in 140 patients with advanced cancer, very well tolerated, with no serious adverse event. When you take the blood from this patient before the injection and a day after, you can see a 5-fold increase in SEPPA in peripheral blood. How long does it last? Well, if you inject it in the tail vein of wild-type mice, it's at least for 4 weeks, it is expressed. So let's talk about MPS I. This is a disease where there is no IDOA. So there is accumulation of GAG, and that causes apoptosis to the cell. As I mentioned to you, MTL-SAPPA produce a protein called SAPPA protein that sit on the enhancer-like region of the IDOA and lead to expression of IDOA. Where is the proof? This is the proof. This is from cancer patient injected with MTL-SAPPA, and you can see how there is increased effect. It's like knowing the result of the clinical trial before you start to put your first patient. It was there for us to see. And what is very nice is that you can predict whether it will work or not in the patient. So if you take a sample of blood and add a drug and leave it for 24 hours, you will notice that there is increase in IDOA. And in the two-chamber assay with Hurler fibroblast, you can see increased IDOA and decrease in the GAG. And that's the object of the exercise. We did it in transgenic mice, and we can see increase in the IDOA expression in the bone marrow cell, in the plasma, and decrease in TNF-alpha. What was really extraordinary is that the distance in the face between the two zygomatic arch normalized, something we didn't expect at all, which was nice to see. We know that there is some 7,000 gene, rare genetic diseases, and we believe that some of them, that patient could benefit from RNA activation, and we are looking for collaboration in, across many rare genetic diseases. And this is a list of potential lysosomal storage disease that could benefit from this approach of RNA activation. As people say, it takes a village. A lot of people, animal model was done at the University of Minnesota, and Michael presented the work 2 days ago. MiNA Therapeutics, the lead in producing oligonucleotide for RNA activation, and that was led by Vic. City of Hope, and in Taiwan, great collaboration. They have a transgenic mice model colony, and Manchester. I'm very pleased to say that Professor Simon Jones is a principal investigator in a study that has been approved by MHRA to do a phase 1/2 study in MPS I-H patient to receive this drug. And finally, I'll be there with my colleague in poster 151. I'll be very happy to take any question.
Okay, I think we are ready for some questions. Dr. Habib, there were quite a few questions about your upcoming clinical trial. Is it going to be in adults or in children? What's the enrollment criteria, treatment regimen, anticipated outcomes, potential toxicities? Do you have any safety information?
Thank you. So we are planning to start with the older patient from 12 to 16. And then when we show it is safe, we'll go down to the age from age 4 to 12. All these patients will be MPS I-H, treated successfully with hematopoietic stem cell transplant, and they would have been for 1 year of immunosuppression. And we have 3 groups of patients with a dose level, 2 in each. And then afterward, there is a phase 2 where they will get probably 1 injection a month for 6 consecutive months, and in order to look on safety, but also on efficacy. And our focus is going to be on the IDUA level and the GAG and the non-reducing end of the GAG. Afterwards, if possible, we'll go ahead with the phase 3 study. And we'll start with 12 patients for the phase 1/2, and the phase 3 will require another 12 patients. We do not anticipate any major side effect because the drug has already been given to 140 patients, and a lot of them are quite ill with advanced cancer. One patient received 150 injections once a week for 3 years. More than 30 patients received it every week for 6 months. Here, we are going to give a third of the dose, and we'll give it every month intravenously.
Thank you. Dr. Habib, what modifications are needed in making a saRNA used in the mouse experiments when you reformulate to treat humans? Do you test in human cells?
Well, it has been formulated for to go to the myeloid cell, and the delivery system go to the myeloid cell. It doesn't go to the hepatocyte, and it doesn't cross the blood-brain barrier. And so it is ideal for patients that had donor from the donor following hematopoietic stem cell transplant because they are normal. And these patients have nothing at the moment. You can't offer them anything. They already had their bone marrow transplant. And in Europe, it is not popular to give them ERT. You cannot give them the Orchard therapeutic AAV, lentivirus in situ, because you need to do a second bone marrow transplant, and you are taking a risk on the patient when the patient is doing well after the first bone marrow transplant. And then you'll have the CD34 positive cell producing the wild type, and then another source, which is from the lentivirus. So it's very high risk. And any drug you develop today, you'll take at least 3 years to take it to the phase 1 clinical trial, because you have to do, apart from the discovery part, you have to do the toxicology, you have to do the non-human primate, the GMP, the approval. This is 3 years. This patient, there is 1,000 children that are waiting, and with time, they will stop walking and they will end up in a wheelchair. So when you have a drug that's already proven to be successful, I think it is very attractive to use it in these patients. Saying that, we are developing a particular saRNA for the IDUA, but that, as I said, will take 3 years to reach the clinic. And every day count.
Thank you. Habib, would other downstream target genes of CBPA be activated as well? Is there any safety concern related to off-target activation?
Yeah, we have taken great care to address this. We did a single cell seq, and we did ATAC-seq. And ATAC-seq measures the distance in the chromatin, how it's open or closed. And so we correlated the two findings, and we looked on 16,000 genes, and there was only 6 that were off-target effect. So it is very, very small. And when we looked on the context of the myeloid cell, there was nothing to worry about. There was no oncogene among them. So we have done the homework. And on top of that, as I mentioned, 140 patients done in 20 centers around the world, 7 centers in the USA, the rest in Europe and Southeast Asia. Not a single investigator reported major adverse event. So on this, I think we are pretty relaxed.
For Dr. Habib, are the saRNAs compatible to be used with new BBB technologies? For example, can it be as a complement with the anti-HTFR? I guess that's a transferrin receptor.
Yeah, I mean, all what we want is to increase the IDUA, and it can be complementary to ERT or to any other therapeutic modality. And I would like to stress that SEPPA gene is a differentiating gene. At an embryonic stage, it's upregulated, and it leads to the formation of the primary heart, lung, kidney, liver. And it decreases any acute inflammation, bring M1 to M0, or chronic inflammation from M2 to M0. It is a steady state gene. So we just want to help the patient by increasing the IDUA. So I cannot see why it can't be used with other modality. But there is, in relation to the previous question, in actual fact, it is a great thing that it upregulates other genes in other MPS. It increased GAN. In these transgenic mice, when you look on GAN, it went up, not only IDUA. So you can take a drug that is safe, and you can repurpose it to more than one rare genetic disease. And as I say, there is nothing that I heard today and yesterday that you can offer in the near future for this patient that already had transplantation. Now, the children that are born in the future, they will be spoiled for choice. They will have the ocean lentivirus treatment and many other treatments that are coming together. We heard today the transferrin receptor, but they don't exist today for these children.
Okay, thank you. Dr. Kim.